Alrighty, this is the fourth installment of basic ECG interpretation. Now, in this podcast, we're going to finish things up. We're going to talk just a smidge about bundle branch block, and we've mentioned those in the previous podcast. We're going to talk about ventricular arrhythmias and then some common things that go along with dysrhythmias and whatnot, including just a little bit about cardioversion versus defibrillation, which I know we talked about before, just a smidge, but we're going to talk about it again. Alrighty, so bundle branch block. Like I told you before when I showed you the picture of the 12-lead ECG, a bundle branch block is a delay. It's a conduction delay or a block in one of the main branches of the bundles of His. Okay, so usually it happens after an MI or with cardiovascular disease. And basically what happens, like I said, is when the electrical impulse goes down through the bundle of His, it's blocked. Something's blocking its way, and so then it has to reroute and go down another pathway. And that's what causes those rabbit ears or those notches in the QRS. This isn't a really good picture of that, but if you could imagine a little notch here, okay, it looks a little different. And that's basically what a bundle branch block is. It can deteriorate and cause the need for a pacemaker. It does make the QRS wide, okay, so that is one thing. That and pacemaking can make a QRS look wide, because we're going to get into talking about wide QRSs and ventricular arrhythmias here in about 2 seconds. But just note that a bundle branch block can make a QRS wider than normal, and so can a pacemaker. So, all right, there are 3 different types of ventricular dysrhythmias that I want to talk about, and one of them are premature ventricular contractions, which is just like a premature atrial contraction, except these come from the ventricle, ventricular tachycardia or VTach, and ventricular fibrillation or VFib. All right, so a PVC, again, the same idea as a PAC, all right, except that this ectopic foci or irritable cell, if you will, originates in the ventricle, okay? And so it overrides the SA node and it just beats, okay? Now, each focus creates the same looking beat, okay? So if you had foci A, and foci A was firing out of sync, and each one of those beats would look different. But if you had multiple foci, so like you had foci A, B, and C firing, then A, B, and C would all look a little different, okay? So those premature ventricular contractions, or PVCs, would look different. All right. If PVCs are more frequent, okay, that means the ventricle's irritable, and chances are you've got some kind of electrolyte imbalance, potassium and or magnesium. Okay, that's usually the problem. So there you go. If you get enough of them in a row, they can be lethal because they do not always produce a pulse. Now, if they produce a pulse, then you do have cardiac output and life is pretty okay. All right. So if they produce a pulse, all right, then you're maintaining your cardiac output and the patient is usually okay. Now, we still need to treat them, mind you, but it's not as deadly as if they are not producing cardiac output. So if they are not producing cardiac output, then you're going to see signs and symptoms of distress, and your patient will be symptomatic, okay? So hypotension. So basically the same kind of symptoms that you would see with your other dysrhythmias, like your tachydysrhythmias, or the bradydysrhythmias, where you're going to have instances with decreased perfusion and decreased blood pressure as well, okay? All right, so again, they can be insignificant if they're infrequent, but the more they come about, the more significance they have. So here are some of the causes, okay, and these should look familiar. They're some of the causes of some of our other arrhythmias as well. Okay. Again, a pictorial representation. So here is a PVC. Look how wide, we call them wide and bizarre, or that's usually how we refer to them, but the QRS is going to be really wide. Okay, so greater than your 0.10. You can have normal beats and then another PVC. So see how it takes over the whole entire beat. There's no P wave, there's no QRS. It's just one big, actually, QRS and T wave. And look how much different it looks. So now, because this is coming from the same cardiac cell, all these PVCs look alike. Okay. On this strip, here's a single PVC. Okay, it's upright. Down here, we have what we call a triplet because there's 3 in a row. All right, so now look, these are downward deflecting, so they look different than this one. So if this was the same person, then you would have 2 different foci causing these PVCs, because one looks like this and the other one looks like this. Now these 3 all came from the same foci because they all look alike. Here's just another pictorial representation. So if the PVCs look alike, we call them unifocal. Okay, so one foci. Right? And if they look different, so this one's up and this one's down, we call them multifocal because there are many foci, okay, or more than one. All right, so how do we treat PVCs? Well, if they are multifocal or they're coming pretty frequently, 6 per minute, if we're having runs of more than 3 in a row, then we probably want to treat it. So chances are we're going to draw labs first and correct any electrolyte imbalance that there is. If the patient's hypoxic, of course, we want to correct that as well. We can give them potassium and magnesium boluses to help correct electrolyte imbalances. Lidocaine, a lidocaine drip has been used in the past, but they really don't use lidocaine too much anymore as far as medications for treatments of PVCs. Usually it's electrolyte and hypoxia correction will usually take care of these. All right, so what's the difference between PVC and ventricular tachycardia, or VTach? Well, it's the length of the PVCs. So if you get a whole big long string of PVCs, then we call that VTach, or ventricular tachycardia. This is a life-threatening dysrhythmia. Okay, so this is where you're going to have the rapid impulses from one foci, 150 to 200 per minute, so it's really quick. So that's why it's tachycardia, not ventricular bradycardia. And it looks like a string of PVCs. Okay, so there are your causes. So heart disease, MI, low potassium, low magnesium levels. Again, that shouldn't be any big surprise because they're your 2 main cardiac electrolytes. And then, of course, drug toxicity would be another one. All right. So, if they're conscious with appropriate vital signs and you're getting a pulse, then they should be conscious anyhow. Then usually, like I said, lidocaine's not used so much anymore. Amiodarone would be your drug of choice, IV amiodarone. So we're going to start them on that. If they're unconscious, then this is defibrillation and CPR. Okay. So defibrillation, remember, is the higher amount of joules or shocking than cardioversion. So remember, with defibrillation, it can be 200, 300, 360 as far as joules are concerned. So the amount of energy that we give through the patient that we shock them with is higher with defibrillation because the patient's heart has stopped. Okay. Cardioversion, remember, on the other hand, is where we're going to try to get them out of an irregular rhythm and back into sinus rhythm, so we don't need to shock it quite as hard, and we shock it with less amount of energy, like 50 joules. Okay. Of course, then if we want to treat the cause, if you know it, electrolytes, if the patient has had drugs, there's multiple H's and T's. If they're acidotic, so if they have hydrogen ions, H ions, if they have tamponade, if they've got toxicity, so like drug toxicity, if they're hypothermic, there's like 7 or 8 H's and T's that we think about when we're looking at VTach or VFib to try to treat the cause. Because if you don't treat the cause, then you can't fix the arrhythmia. Okay? The other thing that can be placed is an AICD, which is an automatic internal cardiac defibrillator, or automated internal cardiac defibrillator, which is a little defibrillator. It's like a pacemaker defibrillator, and when it senses that the heart is going into VTach, then what it'll do is it'll actually give like little shocks to the heart to get it out of VTach and save the patient's life. Now, by little shock, I do mean a little shock, but it can actually throw the patient to the ground. So it's not a little shock to them, but in the scheme of things, it's smaller than what we normally give for a code situation. All right, so again, here's the same type of picture. Here's that foci. It's producing many electrical impulses, and we count them. Now, I always count the tip or the point of the QRS when I'm counting VTAC. Okay, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So if this was a 6-second strip, there'd be 13 beats. It'd be 130 beats per minute. Okay. All right, here's another strip. Here is a 12-lead ECG, and that's just ugly. Ugly. You don't want to see that. Something akin to VTAC, in the middle of VTAC and VFib, is something called torsades de pointe. Torsades de pointe just means twisting of the points. And so basically it's when, here, I'm going to go back. Basically, torsades can happen when you have a beat that's like a normal beat, P, QRS, T wave. If something comes in early, so if a beat comes in early and it hits on the T wave, it can throw you into torsades. Okay, so that's what it's caused by R on T phenomenon. So the spike, the QRS, falls on the T wave, so it comes in early, and it can throw the heart into this type of rhythm. So it's kind of like a mixture of VTAC and VFib. But see how it gets smaller and then bigger and then smaller and then bigger? That's the twisting of the points. That's what makes this special. We treat it the same way that we do basically VFib. We can give magnesium because it's usually an electrolyte problem, and defibrillate. So, all right, so now we talk about ventricular fibrillation. Remember when we talked about atrial fibrillation, that the atrias fibrillate or jiggle, okay, and they don't squeeze or pump? Well, this is the same thing, except this is the ventricles. Now, okay, it was bad enough when the atria fibrillated. It's really bad when the ventricles fibrillate, because now you have no cardiac output whatsoever. Okay, so they're in cardiac arrest, and it can be fatal for the patient. So, this is the most common cause of sudden cardiac death. Okay. And here again is the pictorial representation. You've got lots of foci, and they just, everything, they're firing, and the ventricles are like, wait, I can't handle this, and they just kind of like shut down. They don't squeeze, and they just fibrillate and jiggle like jello. Okay, and this is what you see, just a wiggly spot along the, along the strip. You can't count anything, you can't measure anything, and if you don't defibrillate the patient probably will die. Well, there's no doubt about it. The patient will die. And by the time they hit VFib, it's actually very difficult to get the patient to come back to life once they have a ventricular fibrillation. So, all right, so there's just another strip. There's the 12-lead EKG. That's not so good either. Nobody wants to see that either. Treatment, CPR, and defibrillation. Boom, boom, boom. We can give, for advanced cardiac life support, we give epi, we give amiodarone, magnesium. Again, not so much the lidocaine anymore. That used to be standard drug of choice, but it's not anymore. So epinephrine, amiodarone, magnesium boluses are the drugs of choice for VFib. All right, so here is the cardioversion versus defibrillation. So again, you're applying electricity through the chest wall to depolarize the heart and allow it either to get back to normal sinus rhythm or to shock the heart back to life. Okay. Like I said, one of the main differences is the amount of electricity that is given through each one. So cardioversion is very small, so about 50 joules, and defibrillation anywhere from 200 to 360 joules. The other thing that makes them different is whether or not they're synchronized. Okay, so what that means is that when you cardiovert somebody, when you put them on the monitor, okay, there's a sync button that you can press. And that makes the machine sense each beat. It senses the QRS in each beat, okay? So that it'll only shock them on the QRS, and it won't shock them on the T wave and throw them into torsades, okay? So, and that's, you know, kind of what we want, because we're trying to get them out of like AFib, AFlutter, SVT, We don't want to send them into torsades, which could kill them. Okay, we want to put them in a normal sinus rhythm. So it's going to synchronize and shock them on the QRS and not on the T wave. Okay? Defibrillation is asynchronized. Okay, when that heart stops, so it's either in VTach or it's in VFib. We don't care when we shock them because there is no real T wave. And it doesn't really matter. So defibrillation is asynchronous, cardioversion is synchronous. So here's just a rhythm strip showing that when the patient was cardioverted. So this patient was in rapid AFib. Okay, they got shocked, and once they settle down, then they're nice sinus rhythm again. Isn't that lovely? It is lovely. Okay, this patient was in VFib. Okay, even worse. Shocked them. All right. Defibrillated them, if you will, and now they're back into, well, some kind of organized rhythm. It's hard to tell what that is. It could be coming back into sinus. See how you got P wave starting here, P wave, P wave, P wave. So it's probably back into sinus. So that's good. But then the trick is, do they have a pulse? All right, just a picture of your shock pads, your defibrillation pads. Here's a picture of one type of monitor that we can use. There's a shock button. Somewhere around there's probably a sync button too, as far as syncing for cardioversion. The AED, you know about an AED from CPR class, so I'm not going to go over that. The last two rhythms are PEA and asystole. So here's PEA, right? Look, there's P waves, okay? Kind of looks like sinus tach, right? 2, 4, 6, 8, 10, 12, 14. So 140 beats per minute. Looks like sinus tach. The only problem is they're pulseless, okay? So they have electrical activity going on that you can see on the monitor, but they don't have a pulse. And so they're basically not living, okay? So we start CPR and we do ACLS. So here are the causes and treatments. Usually it's here are the H's and T's, okay? Hypovolemia, hypothermia, hypoxia. Acidosis, which is H or hydrogen ions. Okay? Hyper or hypokalemia. Drug overdose, so that would be your toxicity. Okay? Tamponade, tension pneumothorax, or thrombosis. Okay, so those are your H's and T's. So we try to treat that. That's usually the only way we can save them, but quite frankly, once they have PEA, they're usually not savable, quite frankly. And then, of course, the last one is asystole, or also known as ventricular standstill. Okay, so that would be your flat line, or that's considered to be a flat line as well. Full cardiac arrest, again, your H's and T's could be in play here. You also want to make sure that you check a pulse, okay? One of the first things that you should do when you have any kind of irregular rhythm, VTach, VFib, asystole, anything like that, is check the patient first. Check to make sure that their leads are in place. Check to make sure that they have a pulse, okay? If you see this, and your patient's sitting up and talking to you, chances are they're not in asystole, okay? So, don't be like throwing the defibrillator pads on your patient going, Claire, and shock them when they're perfectly fine because one of their leads came loose. All right, so please check the patient and check for a pulse first. All right. So there are a couple things that if a patient has an MI, there are a couple of things that we can do to try to help the patient recover with minimal amount of tissue damage. All right. And one of the things that we can do is called therapeutic hypothermia. All right. So this is done once the patient has coded and we get return of spontaneous circulation, or we have a heartbeat and they're breathing. Okay. Well, they don't necessarily have to be breathing on their own, but they have a blood pressure and a heart rate on their own. Okay. So eligibility for this therapeutic hypothermia protocol would be that someone witnessed the arrest, so they dropped right in front of you. That they were down or had pulselessness less than an hour, and that they didn't have any cognitive impairment pre-arrest that you know of. Okay. Contraindications to this would be any kind of blood dyscrasia, arrest for greater than 60 minutes, major surgery, recent surgery, or DNR status. So the goal of therapeutic hypothermia is to reduce the patient's temperature to help reduce the amount of metabolic needs of the tissue, okay, and to help decrease the amount of free radicals that damage the tissue because of hypoxic issues. All right. Now, with therapeutic hypothermia protocols, we give the patients all kinds of medications, all right, because we're making them like 92 degrees, okay? We're making them pretty cold. And when you get cold, what do? You shiver, all right? So we want to not have them shiver because shivering, as you see there, or remember, increases oxygen demand, okay, and then increases the body temperature, which is what we are trying to avoid. So we put them on a cooling blanket, and we can cool them down to about 92 degrees. So also, you want to make sure that the patient is not awake for any of this because it's extremely uncomfortable to be that cold. So we give them paralytics so they can't shiver. Okay. We give them narcotics to make sure that they are pain-free. We give them some kind of sedative to make sure that they're asleep. Okay. We usually have something called BIS monitoring, BIS, which is neurological monitoring. We can monitor like their brain activity, basically, if you will. And so we can make sure that, to see how awake they are underneath all of this medication that we're giving them. Now, chances are these patients are also, not, in addition to receiving all of the things I just said, they're also probably on vasopressors and IV fluids, and we're monitoring all kinds of things about them, keeping track of cardiac output and their status while they're recovering. Well, or while we're attempting to have them recover, maybe that's better. Okay. We usually maintain therapeutic hypothermia for about 24 hours, and then we rewarm them usually for about 24 hours. So we monitor core temperature, so we can monitor their temperature through the Foley catheter. We can use a rectal temperature, or we can use something called a PA catheter, or a pulmonary artery catheter, or you might know it as a Swan-Ganz catheter as well. We don't use those as much anymore, but it could be used. But usually, I know where I worked, we used the Foley cath temperature probes, which is nice because then it's just one less probe you have to put in your patient. While they are on this protocol, and especially while we are warming them back up, we are monitoring labs very frequently, like usually every 4 hours. We're monitoring and fixing any kind of electrolyte issues, or we're monitoring lactic acid levels and all different kinds of things to see how the patient's doing. As we wake them up, we're also decreasing the sedation, so we're making sure to see if they are able to wake up neurologically as well. Okay. This does not always work. Matter of fact, it probably doesn't work more often than it does. But for the ones that it does save, it's a very good thing. So it's when your patient has had cardiac arrest and you're like at 50 minutes, that's a long time. It doesn't mean that your patient can't come back, but it's much, the longer that they're down, the more likely it is that they will come back. It's really difficult, but this is at least a method to give us a try to save the patient's life if we can. Sometimes it's enough at least to allow the family some time to come to terms with what happened, and sometimes to say goodbye. So it can at least provide that for the family. And I really don't think that, that the patient is suffering at all, because they're really sedated and, they're on the ventilator. They've got adequate pain control. We're monitoring them. And so, I don't think it's a detriment to the patient. So that's something also to keep in mind. But again, we're watching them for dysrhythmias. We'll have central line. And like I said, at least 4 or 5 medications at least. The shivering, okay, we're preventing that with the use of the paralytic, which is that neuromuscular blockade. The vasopressive type of drugs, if they're hypotensive or have issues with cardiac output, they're on the ventilator, they're sedated, and like I said, we have pain medicine on board as well, and as well as neurological monitoring. So, and that ends the podcast series for basic ECG interpretation.